Hi, and welcome to episode 234 of the Untethered podcast. Today we have Anna Dearman joining us. Anna attended Louisiana State University Health Sciences Center in New Orleans and graduated in 2012 with a Master of Occupational Therapy. She has extensive knowledge and experience in pediatric orthopedic conditions, including splinting prosthetics and equipment management from her time spent working at Shriners Hospitals for Children. She became a certified lactation counselor in 2021 and is currently working towards international board certification by completing the requirements to sit for the IBCLC exam. She entered this space due to the lack of resources in her community. She's currently starting her own private practice, Prosper Therapy and Feeding Solutions, where she hopes to provide the utmost quality feeding care in her area. She's very passionate about the field of occupational therapy and hopes to inspire many of her colleagues to advocate for what they do. Quick disclaimer, all information, content, and material of this podcast are the opinions of the speakers and is for the informational purpose only and not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified healthcare provider. Welcome to the Untethered podcast. I am your host, Hallie Bulkin. I'm a certified myofunctional therapist, feeding specialist, podcaster, business owner, and mentor. This podcast is all about getting your questions answered and collaborating with colleagues to bring you the most up-to-date information in the orofacial myofunctional therapy, airway, tethered oral tissue, and pediatric feeding therapy space. If you're new here, I challenge you to keep an open mind and join my mission to spread this message far and wide. If you've been around since June 2019, thanks for being a loyal listener. As we jump into today's episode, remember to listen with correct oral rest posture. Tongue up, lips closed, teeth apart, breathe through your nose. Let's get started. Anna, welcome to the podcast. I am excited today because I know we are going to deep dive into a topic that is so relevant right now. But before we go there, I do want to just have you share a little bit. Everyone just heard your bio, but I want you to share who you are, what you do, how you got into your specialty.
Well, my name's Anna Dearman. I'm an occupational therapist. I've got lactation credentials now, and I'm working towards all of my requirements to sit for the IBCLC exam, which hopefully I'll get to do in the next year or two. I know, exciting. So I entered this space. Started out my career at Shriners. Y'all may have heard that already. I ended up working at an inpatient rehab in Bossier City as a therapy director for a little while there. So that was good for me to learn a bunch of the medical side of things. I feel like that's really impacted my now career in pediatrics mostly. Just being knowledgeable about certain medications and whatnot has been really, really helpful. But the reason I entered the space is because my second child came out and was having a very hard time with breastfeeding. It really hurt. I can remember being in tears at 3 weeks old. Her second, I think they saw her 2 weeks out for her follow-up, her pediatrician, which is a whole nother story, but we were seeing a med ped in town, and she hadn't really reached back her birth weight yet. At this time I had no real knowledge of anything. I was like, oh, this is fine. She was sleeping through the night when she came home. All the red flags that, I tell parents of now, but, he encouraged me to wake her up to feed her. We did that. We got her weight back good. I knew about lip and tongue ties. I asked him if he thought she had one. He said no. I kept looking in her mouth. I was like, I called the lactation consultant, the only IBCLC that we have in town, to come see me. At this point, she helped me with positioning. And while she was there with me, we had one really good latch. Never had that again. She knew I was an OT. I'm not sure if maybe that intimidated her some. I was asking questions about the ties. She wasn't sure either. We had a dentist in town at the time that was known for doing releases. And so I went to see the dentist. that dentist recommended that we do her upper and lower lip, interestingly enough. The dentist told me that she had a posterior top, but the dentist didn't recommend releasing it because she felt like, the dentist felt like it wasn't impacting anything and that it looked good. So we didn't. Went back home, continued to have issues latching, continued to have issues with my milk supply. I'll look in her mouth again. Her mouth was just so small and tight, and started playing around, found all 4 buccal ties. It's like, is this, anything here? So I went back to her, the dentist, back to her dentist. And basically the dentist was like, yes, they're there. I can release them. Okay, well, here's where, I was working a job that we didn't have leave. So, I wasn't being paid a paycheck at the time. It was like $7.50 per arch.
Oh, wow.
So, I think I got like a 2-for-1 deal for the 2 lips. My insurance did come back and pay me back later. It was just one of those things where I really couldn't justify offsetting the cost of the buccal ties, so I didn't. Our breastfeeding journey ended at 4 months. I got pregnant again at 5 months postpartum. So here we are. This time around, I'm like, and I'm one of those people that, I would love for everybody to have breast milk. Okay. I wouldn't call me crunchy or anything, but, I know the benefits of it, and I just think that it's the best. And if at all possible, I wanted my 3rd child that was well on the way to have the best. 3rd time's a charm, right? Okay. So I go to my current employers and I propose that I take the Healthy Children's Certified Lactation Counselor course. Talk about it for a little while. They agreed, and thank God they allowed me to do that while I was on maternity leave. I completed the majority of it. Well, knowing what I knew of Isla, my middle child, who had a grade 4, got low class 4 with bone notching on her upper lip, I look at my buddy boy, we call him buddy boy. His name's Gray. I look at his. His is definitely, it was a 4, like a caught low 4 too. But his flanged well. At that time, I had not had like TOTs training, and I suspected that he had a posterior tongue tie because we struggled a little bit, but eventually, it got better. The thing with him though is that he wanted to feed every hour, and every hour. My output was fine. At that point, I knew, I needed to pump every 2 hours when I went back to work, that sort of thing. And once I got my credentials, I started seeing patients. Well, I brought him to see the dentist. Everything's good. All right, everything's good. Awesome. His frenum is like at least 4 or 5 millimeters thick now.
Wow.
But anyway, it's a thick one. I have to make sure to brush around it really good. But anyway, everything's good. So we didn't do anything, but we did successfully breastfeed until 14 months old. His latch was terrible. We had to supplement with maybe 3/4 of a can of formula the entire time he was bottle feeding or nursing. So I consider that a success. But yeah, so those are, two examples for me, my reasoning entering the space. Well, once I got my lactation credentials, the people that were referred to me had some sort of tongue dysfunction 9 times out of 10. These were the ones that were low weight gain, pain, clicking on the bottle even. So I'm looking and I'm like, okay, maybe I should do some exercises with their tongue, just to see if I can build up strength. So start doing lateralization and extension and, just seeing what outcomes I'm getting and realizing I have no idea what I'm doing, other than sending them to the dentist that would release them, and then they would come back and still have issues. And I was not able to help them get a deep relaxer. So here we go again. I'm like, oh gosh, what do I do now? Well, I do Autumn Henning's stats course. For me, it was very validating. Hey, I knew I was supposed to be doing something. But also, gosh, I've learned so much now. And knowing that the pre-therapy, the body work, all of the components that need to happen, implementing that into my practice. Wow, that's made a huge difference. Well, here we are. Now I'm working with people's babies' mouths. Well, now people start calling me about their bottle feeding baby. So, okay, here we go. Here we go again. I'm like, okay, now what do I do? I think I did, is it John Pishoff's course for the top savvy therapist. Then I'm like, okay, well, this whole body work thing. I live in Monroe, Louisiana. We have a great little town. We're separated by a river with West Monroe, Louisiana. If you've heard of Duck Dynasty. That's where they're from. So it's a great place to live. It's a great place to raise your children. Monroe is very different from West Monroe, even though we're separated by a river. And in saying that, our access to medical care, we had a few companies that used to be headquartered here, State Farm being one of them, CenturyLink being one of them. And since they have moved out, I feel like our medical community is suffering because we don't have specialists that want to come here. Mm. There's nothing really here for them that's appealing. So I say specialists, even down to body workers. We have 2 female chiropractors that do body work that, as far as I know, and I could be wrong, and now that I'm opening my own practice, I hope to have time to reach out to them to learn more about what they can do for me. But they don't have TOTs training. I referred out to one of them for a bodywork session before this child that I had seen for 4 weeks. And I'm sorry, not 4 weeks, 4 months. And was still having problems with feeding, that had a posterior tongue tie, but he had some body tension. And she goes for the session the day before she's going to get a release. Oh, that's not a tongue tie. That's body tension. Oh, interesting. Have you seen him eat for the last 4 months? At any rate, thanks for collaborating with me before you go off and tell my patient that. But that's just, kind of where I am with that. But so in saying all that, I guess I'm kind of digressing here. I found a body work course for better breastfeeding. And I've started implementing that into my practice now. And I'm seeing like really good results with that. So I'm kind of, I think at the end of my journey here, I've been able to connect with another small rural community in Richland Parish. There's a dentist there that has been trained to do releases as well. And she's very collaborative, in the sense that she sends them to me before she does anything, which is great because the other providers in our community do not do that. And so that's been very beneficial for the patients that I'm seeing. And I've been able to open up my own practice as of today. And then, thanks. I'm still currently at my former practice as well. They've been super supportive for me, in all the training that I've received, and I have nothing but good things to say about them. And I'm sad to leave, but I just found that the environment at a pediatric clinic is not always appropriate for an infant that's trying to feed. So I just felt it best for the patients that I see and their outcomes if I was kind of on my own in a place where there's not another kid having, a difficult time transitioning from, his speech therapy session to his OT session right at the door in the hallway. So that's kind of where I am now. And yeah.
That's awesome. No, I'm excited for you because it does sound like a lot of it's coming full circle for you, right? And so many of us start in these spaces. I think every single person I've interviewed in the past couple weeks came into the space they're currently treating in, whether they're craniofacial sacral therapists or craniosacral fascial therapists. Oh my gosh, send me tongue twister today. Whether they're OT, whether they're SLP, whether they're in the myo or the feeding space. Every single person I've been chatting with, like recently, all got into this space because of like their own children, and then the patients on their caseload, and then it really becomes like your work, and it's like, we were talking in the last couple episodes about how it's been a catalyst for a lot of us coming into our specialty. Like our own children have been that catalyst for us. And, a lot of us go like, I don't want another parent to struggle like I did. I want the resources to be available in the community. I want to be at that sounding board, the person who like lets the parent speak what their gut is telling them and not gaslight them, not tell them or make them think that they're crazy or that this can't possibly be going on, or that, this is normal, because we all now know, like, just because it's common, it's not normal. So I love you sharing your story because it totally came full circle for you. And I also love how you like detailed, like when you're like, okay, and now we've got this group of patients, and that meant I had to like deep dive into another component, and then this component, and then that component. And, it's a lot. And I think for anybody listening who's not familiar, it sounds like, oh, it's just a course here, just a course there. No, like this is like a very big time and financial investment in every single individual aspect that you mentioned. And you're like, you've dove in, you're an occupational therapist first by trade, right? And then now with like, you're going for your IBCLC, you already have your CLC, you're going, you took the TOTS.
Feed the peds too.
Yep, feed the peds, TOTS training with Autumn. I love Autumn. Yeah, I mean, and then, even to go in and take more like body work focused courses so that like what to look for, what to maybe even do in your sessions, and or who to refer to, right? Because I think that's a big part of it too. If you even have the people around you, like, you kind of alluded to, you don't really, or you at least don't think you do at this time. Yeah, it's just, there's so many moving pieces. And one thing I do want to dive into, because this has been coming up a lot lately, just with some turmoil happening in the myofunctional therapy world amongst one of the larger organizations and members of, not that you're part of that, but I think, we were talking before we hit record today, and everybody plays a different role, right? In a sense. And when it comes to whether it's myo or pediatric feeding or whatever. But I think that there is, at least for SLPs and OTs, like me being SLP, you being OT, we can definitely have a conversation around that, because you have a role, you have a seat at this table, and a very important one when it comes to advocating for assessing and treating these pediatric feeding cases, whether they're breastfeeding, bottle feeding, on solids, they are eating with the tube, whatever may be going on. I think a lot of people hear OT and they automatically go, oh, child on the spectrum with a sensory processing disorder who needs to advance the number of foods they eat. And right. It's so it's not just that. And one of the big things that I always highlight is, we can't separate sensory and motor. So let's stop separating SLP and OT, because we need to work together, but also there's a lot of overlap in what we treat. And then if we have different specialties or different things we've dove into, beyond the table, or not the table, the surface level stuff, right? Then that's where you go, okay, it may not be that it's just SLP versus OT. It may just be the individual who may have those credentials too, because it's in their scope, but who's done further training in this area. So all that said, will you share with us so we can kind of just lay this to rest for people? What is the OT's role in tethered oral tissues? I know OTs are qualified to assess and treat TOTs or children who present with tethered oral tissues, but can you speak to that a little bit?
Oh, yeah. Okay. So I just said that, I finished your Feed the Peds course. Well, that all kind of arose because I was seeing kids that had reattached, that were starting their solids. I was getting referred kids that were picky eating, and I would look in their mouth and they would have a Corliss type 1 tongue. What do I do with this? This kid's 3. This kid's 2. At what point, where do I go with this? There's sensory stuff going on. This kid was a NICU grad. This kid was, eating stuff just fine, and now he's not. So I was like, okay, I'm going to take a deeper dive into that. Well, then I was getting referred kids that were 12 that had a Corliss type 1 and needed a release. And so I'm like, okay, I think I'm going to try the myofunctional route. So the first thing I do is go look at how to become a COM. A COM, is that what y'all call them? Mm-hmm. OT is not mentioned on the site at all. I'm like, well, this is odd. So what do? My happy little self writes in, hey, I'm noticing here that you are allowing SLPs, RDHs, dentists. Is there a reason that OT is not included? And can I apply? And I get an email back from the director. And I don't remember who this person is. I'd have to search the email. But basically, it was like, hello, you would have to prove that's in your scope of practice. Huh?
Oh, man.
You need 2 letters of recommendation. You have to show that in your curriculum that you covered the, I guess, I can't remember exactly, maybe something like anatomy and physiology of the head and neck or something like that. Show that your coursework, covers that aspect of it. And I'm looking at this like, what is this? Like, what? So, I go straight to my practice framework. I'm like, I knew it. We'd updated it since I'd graduated OT school. But, I'm looking, and sure enough, I find it where it's listed, and I'm looking it up here too, under occupation, swallowing, eating. Description: keeping and manipulating food or fluid in the mouth and swallowing it. Swallowing is moving food from the mouth to the stomach. That's interesting. So it's right there for everybody to see. And these supposedly well-esteemed, educated people do not know this from our profession. Okay, well, that's interesting. And so I kind of got mad a little bit. And this is kind of where my whole thing is, like, of course we're involved. We're OTs, and I feel like OTs have always been kind of the profession out of all the therapies that are least recognized, but we do the most. If you think about it, we overlap with not only speech, but physical therapy as well. We're looking at your daily occupation. That could be anything. You could be a surfer. You could be a baby that, all you can do is crawl. You could be a 65-year-old woman that had a stroke and all you want to do is bake some cookies. I mean, it's just, there's so many areas we can tap into. We look at leisure activities, rest and sleep. Gosh, I mean, I could go down the framework here.
But you've already said, what you've already said covers Maya.
Yeah,
because you mentioned sleep, rest, right? Your rest posture. Exactly. You mentioned swallowing, prepping the food to swallow. That is what we do in Mayo. You just literally listed everything.
And two, postural alignment, yes. Even in your core area. I mean, that all supports everything up here.
Which you can work on, but traditional myofunctional therapists, if they are not PT or OT, it's not in my scope to address core postural instability or the hips or the pelvic tilts or any of that. I might talk about it and screen for it, but I'm not assessing it to the point of diagnosis and I'm not treating it. I'm referring to my colleagues, and the same goes for RDHs and dentists, right? I
can go with sensory concerns. Who's the one that people are looking to for that? It's the OTs. So in some sense, and no offense, we're more qualified to do it than an SLP or an RDH or a PT. So it's just kind of disheartening to see, here we go again. I don't know if you've noticed, anytime there's a movie and the person has to have therapy, occupational therapy is hardly ever mentioned. I think there's maybe one movie out there where they mention the OT. Newspaper articles. I've even been called a PT. It's just how it is.
Yeah, it's okay. We get called speech teachers even if all we do is feeding. So I get it. I totally get it. But no, I think that you have a really valid point though, because there's a couple big issues going on right now. And, some people know about it, especially if they're involved in the IAOM. If they are a member, if they've taken a course, they're hearing it, they're seeing it. It's been going on for multiple years now. One of the things that happened was the board of directors removed SLPs and OTs from the list of who, and they added, by the way, which was not on the website before. They didn't have a separate section on infants and then toddlers, and they added that. I think that maybe it got added at a certain point, but SLPs and OTs were listed as individuals who you would refer these age groups to, right? This age group 2, along with maybe there's an IBCLC involved if they're breastfeeding or some type of lactation, counselor or whatever, and other professionals listed. Well, they've removed SLP and OT and they replaced that with COM, which is completely illegal. It is completely illegal. It is misrepresenting individuals' ability to work with these children. RDHs and dentists are not licensed to do feeding therapy. And if we are working in a child's mouth or on their face when they are under the age, no, let me back up. A dentist, right, has a license to be in the mouth. I'm not saying that I'm not arguing that. RDHs work in the mouth too. Fine. What I am saying is when we are working with birth to 4, right? Thinking cognitive age, because Myo, as I often say, is really for a child who is has at least a cognitive ability, not chronological age, not they're 4 years old. No, they can think, act, and exist at least a 4-year-old level cognitively, but oftentimes kids aren't even ready until closer to 5, and sometimes not even 6. So there's that whole disclaimer, right? Under that age, it is pediatric feeding therapy. What we do when it comes to tethered oral tissues and myo, upper airway, oral prep phase, bolus, all that stuff, this is pediatric feeding, and it looks so different at this age than it does with a 5-year-old. It looks different than it does with an older child, a teen, or an adult. It is completely different. We can't just adapt what we're doing to these younger ages. No, it requires a license, the license of an SLP or an OT, and arguably even a PT, because they have feeding in their scope too, especially when it comes to oral phase. So this is something I'm so super passionate about, because this has been an issue and it says COM, which basically opens it up to anybody with a COM, which could be currently SLP. There is one PT. I believe there's only one so far that's gotten a COM, and because for the same reason as OTs, they just don't allow PTs to take their courses or get certified. And RDHs and dentists, which I'm sorry, I love my RDH colleagues and my dental colleagues, and I have a lot of friends and work with a lot of really great individuals in these who are RDHs and dentists who do, work in their scope just like I work in mine. Unfortunately, the board of directors and some of the big names making these decisions are working out of scope, and there's a lot of big issues going on behind the scenes, which we won't dive all into. But this is one of the reasons why I started a myo course I launched a myo course in 2021, because the IOM has been like self-imploding for years. And it just keeps getting worse and worse. And everyone says, oh, it's the gold standard. The gold standard of what? The gold standard of keeping licensed professionals from treating the patients that they're qualified and licensed to treat, but then allowing non-licensed individuals to then touch those patients that they're not licensed to treat? Like, that's the gold standard? Sorry, but no, right? And so, yeah, so like when you say that OTs, are qualified and maybe even, more qualified in certain situations, yeah, like you guys have a lot of knowledge and 100% should be in this space, in my professional opinion. And I'm an AOTA provider. My company provides CEUs to OTs and to SLPs through ASHA. Yay. And part of it is because I was like, holy moly, why don't we have OTs doing this? You guys need to know this information. These patients are sitting right in front of you. You could be working on this right now along with the other stuff you're already doing. And when we're talking like ped feeding, our littlest ones, you're already doing it. It's just a matter of like adding a different lens and maybe adapting a few other little things in your sessions of what you're already doing in pediatric feeding to encourage nasal breathing, to encourage proper oral rest posture, to encourage proper chewing and swallowing. But again, so many of us are already doing that because we are licensed to, and those of us who are trained to do it are already doing it, which I know I've said 15 times already in the past 2 minutes, but it doesn't seem to be sinking in. So anyways, that's my little rant today, and I don't know where we'll be several weeks from now. I know like while we're recording this, like this is the day before the board, everyone's voting for who's basically gonna be on the board. And they have eliminated seats on the board of directors, and the entire board, not the board of directors, but the entire board is now been made smaller. And they've only moved one SLP onto the board. Everybody else is RDH. So now there's all this like turmoil between individuals online because everyone is feeling like this feels very calculated, and it feels, like because of, and I want to put out this disclaimer too. Again, I love my RDH colleagues. I love my dental colleagues. This is not the profession as a whole. Unfortunately, there is a group of bad apples, if you will, that are doing this. And at the end of the day, I want to stay out of all the politics. I don't want any part in this, but I can't stand by idly and not voice my opinion when it is causing misrepresentation of credentials and leading to potentially harmful behavior with patients. Right. I mean, this is where, it becomes a legal issue because misrepresentation of credentials and what someone can do from a nonprofit organization per their website, that's where we start to get into, there's maybe they say it's not malintent, but it looks pretty malicious to me. Yeah. You want to do this work, go back to school and get the license.
Right. Exactly.
Yeah. So anyways, so I know that you and I both agree, like OTs are qualified, highly qualified, especially when you go and take the courses. And again, that's why I opened it up to OTs and PTs, because I was like, we need a certification that allows you all to take your license, that allows you to do this and learn this information. And if you want to get certified, great. If not, hey, here's the course, right? Like, let's go help our patients. At the end of the day, that's the goal. But so often, I agree with you. I see OT left out of the equation. And one of the things that you and I were talking about for a few moments before recording too was how there's this discussion online in a group right now about, like we really got to advocate for our profession and we need to go do X, Y, and Z. And I was like, I think SLPs and OTs need to be advocating together for our profession and for what we do, because again, there's just a lot when it comes to feeding, there's a lot of overlap, right? So anywho, that's my whole spiel.
Well, validating to know that there's turmoil. And, you know, I don't know, maybe it'll resolve one day to where OTs can easily apply. But
Yeah.
it's just, I was just kind of shocked and taken aback. Like, what?
Yeah. Well, and I think that's also why there's other individuals who have created other courses and certifications. You know, that said, there are a lot of courses that just let anybody take a myo course and let anybody practice myo
Yeah.
without any of these credentials, which is also scary. This is a medical, like we can bill insurance for this as SLPs and OTs.
Yeah.
We can bill this under feeding. We can bill this under feeding. And then some of the other work you're doing, you know, I know you guys can bill under your OT codes as well, because I have OTs in my practice. So I know what that looks like, especially if you're working on core strength and stability and, you know, some of that stuff. You know, my OTs may be working on various things and they have even more flexibility than I do as an SLP to bill different codes to insurance. Not that it gets the best of reimbursement, depending on where that may be going, but we're private pay. So, you know, we just try to help our patients with a super bill the best we can. But I do think that also opens up a whole nother conversation, because there's actually courses where they're teaching, you know, non-SLPs and OTs and PTs and basically how to bill for this. But you can't. It's completely bogus. You can't if you're not a medical professional who has its license. So you can't use our codes, you know?
Right.
Which I think actually makes it more challenging for those of us who are able to use these codes, because that's confusing to insurance, which is already a total shit show.
Yeah, exactly, for sure. And like some of those codes are listed for OTs and speech only anyway, so that doesn't make a whole lot of sense at all.
Well, that's what I'm saying. Exactly. Like 92526, right?
Right.
We can bill that. I don't know if PT can or not. Maybe they can, but I know SLP and OT can, but that's it. It's only like our code.
Yeah.
Yeah. And then as far as like diagnosing goes too, you know, I think there's some of the other things that I think are coming to light that, you know, need to be discussed, as well as the medically complex population, whether it's a child or an adult, because a lot of these patients are not appropriate for traditional myo. And maybe we can, again, adapt myo to their interventions. But if they're coming to us, like you said, if they've had a stroke, or let's say they have a syndrome, or they have something, right, you know, going on, there's always more than an orofacial myofunctional disorder. That may be present, and that may absolutely be something we should treat them for. And maybe, you know, maybe a professional who's not an SLP or OT, like maybe a dentist or an RDH, can absolutely work with that patient. But beyond the OMD, beyond what's going on in the orofacial complex, that needs to be treated by another provider. And we're seeing, I think, yeah, go ahead.
Yeah. I can't tell you how many times I've gotten an infant that from the release provider prior to the release that had a lot of other medical issues going on, and that some of them I still haven't sent for the release because it wasn't appropriate for that child. And just think about all of them that fly under the radar, you know?
Yeah.
It's very disheartening. I'm just thinking of all the kids that go on with, you know, plagiocephaly or, you know, torticollis, and that's just skimming the surface. I mean, I'm talking laryngoplasia, like all those things that are missed.
Yeah. Yeah. I mean, I kind of have this like rule in my practice where just because a parent comes and says, oh, we're going for a release and I want to have my child's, you know, tetheral tissues released. Well, what does function look like? Like, to your point, like, let's assess function and see, like, obviously I can't decide that and you can't decide that. And when it's presented to you by a release provider, then as a parent, you get to decide yes or no, right? But you don't get to walk in and say, release my child. I mean, you can, it doesn't, probably not going to go anywhere. I can't tell you whether or not a release is needed, but I can tell you if the tissue's tight. I do diagnose. I just can't say that you need a release for sure. And my goal at the end of the day is to avoid one if we can. I would love nothing more than to avoid no matter how minor that surgical procedure may be, it's still a surgical procedure. It's still, you know, some people call it trauma to the body. It's trauma to tissue, even if it's a tiny little area. I mean, a cut or a scrape on your body is trauma, right? So when we start to look at it through that lens, I think that we have to remember that like people first. These are people, and you're going to rock their freaking world if you just go and release this child and this family's not prepped, the baby's not prepped, the adult's not prepped, whatever the age, there has to be preoperative work.
My favorite is, here, we're going to show you a video while your child is getting their procedure done on how to do your stretches. I'm like, come on, we've got to give them a little more preparation there. How distracting would that be, trying to watch this video while you know your child's having a procedure done?
Yeah.
Yeah. And then, you know, I don't know. I'm gonna stop talking.
I know. It's like before we put our foots in our mouth. No, I'm okay. I'm good putting my foot in my mouth. I'm good. No, I think this is a huge issue. And I think that we've dedicated a lot of time on this podcast over the years talking about this issue because it keeps coming up. It hasn't been fixed yet, right? This is still a problem that we have, unfortunately, not been able to solve. And so at the end of the day, like if a provider, a parent, a patient hears at least one episode here or there from this podcast and feels that much more empowered to be like, you know what, I heard that like we need to prep for this release before we go for the release. Like we're going to hit pause and we'll come back to you. Like we're not saying, no, we're not doing it. It's just no, not today. Right? Like it is okay to say, no, not today. We're not ready, because that should be a team approach. And the issue that I take with it is even when we have pre-op, when we have prepped a child, sometimes feeding gets worse before it gets better. We don't know what that's going to look like until it happens. And that's something that we have to tell parents. There's inflammation. The child's going to be a little uncomfortable. They're going to have disorganized feeding because now they've got this, you know, their tongue is free, if you will, and they don't know how to use it because it was tethered. And so while we prepped them with the anatomy at the time. And now they're going to have to adapt to their new anatomy, which is why we're going to try and teach them as much as we can before. And then we're going to go right back in there and continue that work so that we can hopefully shorten that window of disorganized feeding, swallowing, you know, transferring milk, solids, whatever. So I think it's so critical that people understand, like, we're not just trying to tell you to spend more time and money. We're telling you you're wasting your time and money by going for a release without doing this other work, because most of the time it doesn't do anything because you now just have a tongue that's sitting on the floor of the mouth. And I will say it's more so with the tongue. I've seen this more with the tongue than like the lips or the cheeks, but you know, it gets worse sometimes, and it gets so much worse. And like, why rock that boat if you're not going to even know what to do? And then you call frantically because now your child's not eating well at all. And they're, you know, sometimes these kids were feeding great. Sometimes they weren't feeding great. It doesn't matter. We see it in both populations. And, you know, I'll let you speak and I'll turn this back over to you. But like, I think
I'm glad you touched on this because this is exactly when I stopped talking and said, okay, I'm just going to start talking now. This is exactly what I was going to say. So you just took all the words out of my mouth. I was just trying not to like, you know, go on my rant about it, but absolutely.
Please do. Go there.
Transient worsening after. And the parents aren't prepared for it. So they're thinking, oh my God, what have I done? I've done this procedure and it's not worked. And then they go into this frantic panic. And then the next thing you know, they show up in my office and I'm like, here we go. Because the child had no pre-work done. That tongue's going right back down where it was. It's already partially reattached. And then I'm having to tell this parent that. And it's just not fun for me, number one. And then obviously not fun for the parent or the baby because it is trauma. It's not trauma only to their mouth. It's trauma to them. They remember this stuff. They remember it for a long time. And,
and the interaction, right, between the feeding dyad, there's some trauma there. There is definitely an impact in the relationship and the connection. And like, you're an OT, maybe you can speak to some of this more too, but fight or flight versus rest and digest, you know, if we're not going to make progress if we're stuck here.
No, 100%. What is it? A little bit of like polyvagal theory? Like, you know, the baby's going to feed off how mama's feeling. And when mama's feeling frantic, the baby's going to feel frantic. Nobody's going to relax. Tension's going to increase. Feeding's going to be worse. You know, mom needs to be prepared mentally for this. And a video in the waiting room is not doing it.
No, definitely not. If anything, arguably, it's probably increasing that like fight or flight because it's like, oh my gosh, I'm already anticipating my baby's going to have a response to this that, I don't know what's going to happen. I don't know what's going on back there. Like they're already worried and now you're going to give them work while they're worried. Like the whole
Right.
idea of pre-op too is because some kids only need a couple weeks and other kids need months. We don't know that, right? Until that child is sitting in front of us. And
Exactly.
part of doing that pre-op work also empowers and educates the caregivers so that they're able to take what they're being taught and feel really good about it. Like we're in each other's mouths. I'm like, do it on me. You don't have to do it on your kid. Do it on
Yeah.
me if you want to, right? I'll do it on you. Like, let's see how it feels for you so that when they do it on their baby, they're confident and they feel really good about it. And they don't think they're going to hurt their baby because guess what happens when your baby's crying after a release? You're going to be like, I don't want to make it worse, right? And the parent's kind of going to like back off because they're afraid of hurting the child or, oh, you know what? They were crying. They stopped crying. Not to say every child cries, but you go in their mouth and they just had a procedure, they probably don't want you anywhere near it,
Mm-mm.
Yeah.
Absolutely not.
Yeah.
So,
And and this is not to like make the whole experience sound horrible and I don't want anybody to be afraid to go into this if that is something that you need. The
yeah.
point is like if you want it to be a calmer experience and one that you feel really good about and one that you feel like your child benefits from, that pre-op is necessary. It's non-negotiable. And honestly, when families are like, we're not doing that, then we're like, we're not working together
Yeah.
because you're setting all of us up for failure, but it's going to be hardest on you. And I don't
Right.
want to see you do that to yourself and your child. So maybe like we're not the practice for you, which I don't want to turn people away, but if you're not willing to do the work, then don't do the release.
Right. Exactly. And one of the things that I like to do is go through it with the parent, make sure they know how to properly do the stretches, make sure they're comfortable with doing it, give them tips and tricks on how to do it if the baby's fussy or crying, just reassure them. I give them my cell phone number. I let them contact me at all hours. Sometimes you just need that support person. And I didn't have it,
Yeah.
So that's kind of, my way of giving it back.
Yeah. Well, and I think that the other thing that you touched on earlier too, which is a big theme here on the podcast, is collaboration. Because I do think at the end of the day that the dentists or release providers, whether it's an oral surgeon or whoever, I don't think they're releasing to cause harm. I truly do not.
No.
But also, yeah, but if like your ego is so big that you won't have a conversation with me about collaborating on patient care and creating a protocol for us to work together because you're too busy or you feel more important or you've been doing this much longer than me or whatever it is, because I've heard it all. Unfortunately, we can't just say, well, I don't want to work with you because sometimes that may be the only release provider in the area or it's one of two or three, right? So it kind of becomes tricky to be like, oh, well, we just won't refer there. Well, okay, what if a patient ends up going there anyways? Like we have no control over that. So it's, while you're not going to change a provider, at the end of the day, I'm like, look, like I want to refer to you, but in order for us to do that and have this collaborative relationship, like, can you give me 20 minutes of your time so that we can sit down and like hash out what basically a plan and a system, if you will. It doesn't have to take long because I've had some of these providers on here who have these systems and they're beautiful. And you don't have to reinvent the wheel. They already exist out there. It's like go listen to an episode of, with some of my release providers and they detail like what's required step 1, step 2, step 3 before they'll ever go for a release. So anywho.
Well, yeah, I definitely admire those who collaborate because ultimately you're doing what's best for the patient, not for your practice. I feel like some of the release providers feel like they're doing their patients a favor by not having them come in for a second visit to have it done. After their consultation, they'll just do it then. Or maybe that they are busy and they don't want to have to block out time again to see the patient later to do it. And I understand that, I guess, to an extent, but like you're saying, if you don't have the time to carve out for me because you're too busy, like that really is kind of not the way I want to be anyway. I'm actually, I just discovered through your Feed the Peds alum group that there's another OT, yay, in West Sonora across the river that has the TOTs training and is doing some of this too. And I'm actually meeting with her next Friday. So like I'm not above, collaborating with even a colleague to help get this done. I mean, it's all about the patient at the end of the day, not about me or my practice or anything like that. You know, I just want to be able to approach the providers in our area that aren't aware, maybe, or aren't willing to listen. And maybe if we do that in a united front, they might.
Yeah. Yeah.
So,
no, I mean, I think that whole collaboration over competition thing that you're, speaking to here is so powerful, because like, why did we even get into these professions in the first place? To work with
right.
patients, to help patients. Maybe we got into this with a different specialty or subspecialty under our licensure in mind, and we've changed course, fine,
Right.
whatever. At the end of the day, we all got into this because we wanted to work with humans and help humans, whether they're pediatrics or adults, right? And so I think so many of us, like, and I do truly believe that's true of individuals who go into medicine, period, right? They want to work with people and they want to help people. And I think, unfortunately, at least in America, the way that our healthcare system operates, it's just moved so many of us, not me and you necessarily, but like, I've worked in the schools. I haven't worked in a hospital or an insurance-based private practice. I've only been I've only been in private pay, private practices, like one prior to mine. But I see from all the private practice owners that I coach that have moved out of other facilities, or that, own a facility and they do take insurance. I see what happens. And I see, not that this is happening in their practices, but I see how hard they fight, reimbursement, and they advocate for what they're doing, because in reimbursement's so low, it impacts who you can pay, how much they can, invest in themselves to even learn a specialty area, and how much you can invest in your employees, and the hospitals truly are the ones that have the upper hand and can bill whatever they want for whatever they want. Which is like, okay, fine, but then allow everybody else to do the same. It shouldn't matter where you're located and where you're providing these services. Because again, at the end of the day, I think it drives the way it changes how therapy is done. And I know that
how therapists view their profession as well, because, okay, for example, how much is school nowadays?
Like university, college?
Yeah, like going to occupational therapy school. Okay, we're moving to the doctorate. All right. Why? So somebody else can make more money? What is that going to do us any good for? We can't write scripts. We can't diagnose. We'll never be able to. Why do we need a doctorate? It's to fill somebody else's pocketbook. But in turn, what you're doing is you're going to start an escalation of people not going, or a de-escalation, I guess you'd say, of people going to OT school, because you come out with all this debt, but yet we cap out at a certain salary because our reimbursement rates aren't good, right?
SLP
and then you have job dissatisfaction. You have this low salary. How are you going to better yourself? How are our OTs going to better themselves when they don't have enough money to spend on a specialized CEU? Where does that money come from? So I see a lot of therapists getting stuck in a rut. They'll go on occupationaltherapyceu.com for $100 a year and get their 15 CEUs that they need, and then stop. I mean, I'm not trying to brag on myself. I've done this so that I could help my patients this year, but I probably won't continue doing this many CEUs this year. But I've done like over 60 this year alone.
Yeah.
And I'm just like, just now, I mean, there's been a lot of discussion in some of these occupational therapy groups online too. I'm just discouraged about joining the profession. I've got all this debt. I make $60,000 a year. I'm like, how do you survive? How does our profession survive? I feel like we're very underappreciated. And then you're going to change to a DOT and make it even harder, And so now I feel like in the coming years, there potentially could be a shortage of us. And then we're going to be, again, overworked, underpaid. I'm trying to think of ways to advocate for our profession, whether it's reimbursement rates. Medicare in Louisiana is probably one of the lowest in the country. I'm just speaking out loud here, but what do we do? Where do we go?
Right. No, I mean, at the end of the day, it all comes down to money, right? So it's whoever is running the show up there and making the determination of how much gets reimbursed based on the location, not the code, not the amount of minutes, but the location in which you're providing the same type of therapy. And like, look, I understand that it might take more money to run a hospital than it might to run a smaller private practice, but that's irrelevant because they all have individual groups within. So when people come at you with like all this, like, but you got to consider this and you got to consider that. Fine. Well, then have some kind of a scale where it makes sense, because it doesn't make any sense right now. And you're basically pricing people out of being able to take insurance. We can't accept insurance if we can't keep our doors open and put food on the table for our families, which is one of the reasons why my practice has always been private pay. But we try to help our patients. We give them super bills and we will try to advocate for them to get like a gap exception, which means that they'll get paid at the in-network level, but they have to front the money to us and then submit on their own to get reimbursed by their insurance at that in-network level. Then there's some times where actually their out-of-network benefits reimburse them higher than if they went in-network, which is completely opposite, because it used to never be like that. But I've seen that. I can't tell you how many times in the past 8-9 years of having a practice. So, I think also people just don't know how to play the insurance game. Patients, when I say people, I'm talking patients. And we give them guides. We're like, call your insurance and ask them all these questions. They're going to tell you that like none of this is guaranteed, and that's true. But do your research, like know what you do have available. And then, especially in your area, if there is not another person who has the specialty that you have, your patients, whether you're in network or out of network, should be getting reimbursed at the highest in-network level allowed, because, so I share that in case someone else is listening where they're like this, because I know the insurance thing is like such a big conversation, and this is as far as I go in that conversation. I don't have I've never been in network. But I do think that at the end of the day, like I advocate for my patients in the way that I'm able to, and in the way that I know. And if I can get them reimbursement, or at least help them get themselves reimbursement because they're paying for that insurance plan, or they have some kind of an employer sponsored insurance plan or whatever, then, we will do that. But it's still, it's not a lot compared to other professions like you were sharing. I think OT and speech are very similar in having some of the lowest reimbursement rates, unfortunately. So yeah,
and given the importance of our role, it's just like,
I mean, you need to be able to speak and breathe and eat. Yeah. I mean, what's the number one thing you need in life? Airway. You need your airway. You need to be able to breathe, or, and then the second thing after that is eating. So the fact that like the professionals who, like, obviously there's respiratory therapists and others who deal with the airway, but the fact that like these are two big things that like people come to us for, and that it makes no sense. Like, make it make sense. Yeah.
I don't know. I might have to get like a little rally going.
There you go. I love it.
Petition our legislature. Yeah. The majority of my area is rural. I can never say that word right. You know what I'm trying to say.
Rural. I know.
Well, yeah. And a high percent is Medicaid too. So, I'm here to serve everybody, not just the select few, but yeah, reimbursement. And then they can come back and take it back at any time too. That's what's so crazy about it.
Which makes absolutely no sense to me. Absolutely no sense, for like absolutely no reason.
Oh wait, give me all that money back because you didn't put the right time in.
And you're like, but I did. And they're like, but you didn't. And we're like,
time. It looks like you treated that patient at 3 a.m. Really? Really? Like, I'm serious.
No, I haven't heard about like that, which it doesn't surprise me, unfortunately. I've heard of them coming back and asking for money back for like overpayments, which, okay, fine, I get that. But also it's so hard to, I think, for people to track, like, you're usually not getting your reimbursement, you're usually fighting for it to even get paid as a practitioner who's providing insurance-based services. So the fact that like you get a check and then you have to like go cross-check your books to make sure that they sent you the right amount of money, or that whatever. I've heard so many interesting stories where, and then other times where they've just said, nope, give us the money back to the patient XYZ. And you're like, that has no bearing on my practice. Like, go talk to the patient or go talk to those other providers. Like, they used my services first, and, it was the order of how it was billed by which practice. And it's just so convoluted. And I don't think people realize how deep rooted the issues are, again, unfortunately. But so do you take insurance in your private practice, or are you private pay? What does that look like for you?
A little both. So I'm thinking I had 4 patients scheduled today, 3 are private pay. And then I'll do the super bill thing. But after talking to you, I'm thinking about going ahead and reneging on some of these contracts and just doing cash pay altogether.
It's hard, right? Because like you said, you want to be able to serve your community, and I don't know. I think again, like maybe it's worth a try, and you see how it goes, and you can always back out. Some of them, I have heard of some insurances reimbursing at higher levels and being easier than others, and then I've heard of others just being complete nightmares. So, it's all hearsay because I've never been in network. I've only been on the out of network side of things. So don't do anything based on what I shared because it's all hearsay. But
well, you're learning, huh? Did that sound?
Oh yes. Oh yes. So where can everybody find you if they're like, oh my gosh, I live close to you. Like, where's your practice? How do they get in touch with you?
Well, I just started Prosper Therapy and Feeding Solutions, and I'm off North 19th Street in Monroe, Louisiana. I have a website, prospertherapyla.com, but I have not let it go live yet. Still kind of working on things. Things have been, like I said, a little wild for me. I'm still at my previous job too, and I'll be back and forth for a little while. So, I'm excited.
Awesome.
I'm really ready to start collaborating with other people because, as I tell my patients, as all physicians are not equal, all OTs are not equal, all SLPs are not equal.
Yes.
We all have individualized training. Some may have more than others. I do this. Can I do all the other things in pediatrics? Absolutely. I've done it for the last 6-7 years. So I mean, I'm not above just treating general pediatrics either. It's just that I feel like there's so many out there that need the lactation and feeding services at this point.
Yeah. Well,
So
I love this. I'm excited for you. It's obviously so needed in your community. And so I love that you took the leap and you're doing this. And so, these episodes live on. So even though at the time of recording, the website is not live, it will be in the show notes so that everybody can find you in the future. Once it does go live, in the near future for you. And yeah, congratulations. It's so exciting.
Well, thank you.
Yeah. Thank you so much for joining me today.
I've enjoyed talking to you. Thank you for having me on.
Thanks for listening to this podcast. If you found value in this episode and want to hear more of these MyoTOTs airway and feeding related episodes, be sure to leave a review on Apple Podcasts and share this episode on your social media platforms. You can access free resources and all I offer at halliebalkin.com or pop over to @HallieBalkin on Instagram to get all the latest updates.